Hello friends, this presentation will be on obstructive and restrictive pulmonary diseases, which actually constitute quite a bulk of all the lung diseases, and we can say that all diffuse pulmonary diseases, they can be classified into these two broad categories. And as per definitions of obstructive and restrictive pulmonary diseases go, obstructive diseases are characterized by limitation of airflow, which usually results from an increase in resistance caused by partial or complete obstruction at any level. Now, when we say partial or complete obstruction, we have to understand the concept of intrathoracic compression or obstruction, or extrathoracic compression. If the compression or if the obstruction is mainly intrathoracic, there will be problem during expiration. If there is an intrathoracic compression, that means there is something inside the chest, and when there is an extrathoracic compression, there will be problem during inspiration. So that is why if there is some kind of a pressure from outside, the patient will have stridor, right? Because it is an extrathoracic, and that time there will be a stridor which happens during inspiration. Whereas in most of the obstructive diseases, you will have problem with the intrathoracic obstruction. As far as restrictive lung disease are concerned, they are characterized by reduced expansion of lung parenchyma. The lung parenchyma is basically infiltrated by something. That infiltration can be water, that infiltration can be fibrosis, that infiltration can be pus, and that infiltration can be even a tumor. So the things are basically, so the lung is having a reduced expansion because of that, and it will be always accompanied by a decrease in total lung capacity. Now, coming to the concept of obstructive and restrictive lung diseases, we have to understand one thing, that these obstructive lung diseases, when we talk about the word, when we say this word obstruction, when we talk about obstruction, this obstruction is basically of the air, right? This obstruction is not of the blood, this obstruction is of the air. Does it involve the small airways or it involves the larger airways? Yes, it basically involves your small airways. There are some diseases which initially involves the larger airways, but eventually they will end up having the involvement of the smaller airways. Now, this obstruction, is it during inspiration or is it during expiration? As we have just discussed, this will be during expiration. So during expiration, the air is entrapped within the lung. So there is compression, the air is entrapped within the lungs, and this will lead to hyper expansion of the lung. That means if you try to squeeze the lung out of squeeze the air out of your lungs, you have to do a very basic spirometry test, and that one will be the forced expiratory volume at 1 second. So if we try to push the air out of your lungs, the forced expiratory volume at 1 second will be, the FEV1 will be reduced, right? So this is one of the major thing which happens in obstructive lung diseases. Whereas the forced vital capacity is either it is normal or it is very mildly reduced. So if we have to take a ratio of FEV1 over FVC, it will be reduced, right? So this is going to happen in cases of, if we take a chest x-ray in these patients, the chest x-ray, there will be more air, so they will be more lucent, so they will be more darker as compared to the chest x-rays as we see in other diseases. So they will be, because of more air, you will see that they will be hyper expanded lungs. Now, in comparison, we have restrictive lung diseases. So to understand the concept of these restrictive lung diseases, we have to understand the concept of compliance. You know what compliance is? Compliance can be very well elicit with the help of an example of a sponge. Like if the sponge can be easily squeezed, that means it is compliant. If it is difficult to squeeze the sponge, it means it is less compliant. So the problem in restrictive lung diseases is that they will be having less compliance. They are having less compliance because they are infiltrated. They are infiltrated with something. So that infiltration is basically in the interstitium of the lung, and they can be infiltrated by fibrous tissue, they can be infiltrated by pus, they can be infiltrated by tumor, or just anything which can go inside the lungs, right? So they don't have any problem with FEV1. So FEV1 is basically, it always remains normal, and so is the case with FVC, the forced vital capacity. It may be slightly reduced, but it is reduced proportionally. If it's again, it is normal or it is slightly reduced. So what happens to the FEV1 and FVC ratio? This ratio stays normal. There is no much difference in the ratio of FEV1 to FVC. Now, what will happen to the chest X-ray? If we have to take the chest X-ray, they will not be hyper expanded. They will be having less amount of air in them, right? So there will be loss of compliance. They will be having less amount of air because of reduced gas transfer. So of course we have to understand that they have reduced gas transfer. So the transfer of gas within them. So chest X-ray will have a ground glass appearance. Right. Now here we go. Obstructive lung diseases, there is limitation of airflow, which is due to increase in resistance caused by obstruction at any level, whereas restrictive lung diseases are because of reduced expansion of the lung, as we have discussed earlier. The total lung capacity and the forced vital capacity, they remain normal or it is slightly reduced, whereas forced expiratory volume is reduced. So though the FEV1 to FVC ratio will be reduced a lot. In this case, total lung capacity and forced vital capacity are normal, or it stays normal or it is mildly reduced, whereas FEV1 also remains near normal, so that the ratio of FEV1 to FVC will always remain normal. Some examples, we have these 4 main culprits, which are emphysema, chronic bronchitis, bronchiectasis, and bronchial asthma, which will comprise the obstructive lung diseases, whereas the chest wall disorders in presence of the normal lungs, acute adult respiratory distress syndrome, pneumoconiosis, sarcoidosis, Guillain-Barré syndrome, interstitial lung diseases, all these diseases, they come under the category of restrictive lung diseases. Yes, so the FEV1 FVC ratio is reduced, whereas FEV1 to FVC ratio is normal in cases of restrictive lung diseases. So the 4 diseases which are under the category of obstructive pulmonary diseases are emphysema, chronic bronchitis, asthma, and bronchiectasis, and we will be discussing these 4 diseases one by one, but today's discussion will mainly, so this presentation will mainly be on emphysema and chronic bronchitis. Now if we have to understand the concept of these diseases, it is mainly all of them are obstructive, all of them are problem at the during expiration. We have to understand the concept that emphysema is more or less a morphological diagnosis, whereas chronic bronchitis is more or less a clinical diagnosis. Both of them are irreversible. We have one disease called as bronchial asthma, which is basically a reversible airway obstruction. It means the airway obstruction can be relieved in cases of bronchial asthma. The 4th one, bronchiectasis, is actually not a disease, but is a concept. Any disease, any of these obstructive lung disease can mainly end up having bronchiectasis. So all the obstructions, all the obstructive lung diseases may end up having bronchiectasis, and we will see how bronchiectasis really occurs. Now, this emphysema and chronic bronchitis, they really go hand in hand. Emphysema mainly involves at the small airway levels, whereas chronic bronchitis starts, as the word say, bronchitis. It basically starts at the level of bronchus, but as the disease advances, it also involves the smaller airways. Two two common things. They are quite, they go hand in hand. You can't have a patient, you can really have a patient, you can't really have a patient who is having emphysema without chronic bronchitis, or a patient having chronic bronchitis without emphysema. Emphysema can be seen in all these diseases. Emphysema is basically a morphological problem. That means there is destruction of the smaller alveoli, smaller airways, and the alveoli. So that is what is emphysema. Uh, These diseases, both emphysema and chronic bronchitis, they generally coexist. And why do they coexist? Because they have one common culprit, and that major cause which leads to both emphysema and chronic bronchitis is yes, it is cigarette smoking. So they both are seen together because they can coexist because of smoking, which leads to both these diseases. So smoking is something which can lead to emphysema and chronic bronchitis. Now, this emphysema, in some cases you may have a pure emphysema, in some cases you may have a chronic bronchitis, you may have asthma which is associated with chronic bronchitis, you may have a chronic bronchitis which is complicated by asthma. So all these things have a large, more or less they actually overlap, and they all finally may end up in having bronchiectasis. Now, starting with emphysema, this is characterized by abnormal, the word is abnormal, permanent enlargement of the air spaces distal to the terminal bronchioles with destruction of the walls without fibrosis. That means they will involve the areas which are quite distal to the terminal bronchiole. That means all the smaller airways are the ones which will be involved. So any kind of obstruction will lead to overextension, will lead to hyperexpansion of that particular terminal bronchioles, and will lead to dilatation of the air spaces, which will be permanent. So this permanent enlargement of the air spaces, over a period of time they will break, they will be having some kind of destruction of their walls without fibrosis. There will be a very little amount of fibrosis, but if you see a lot of fibrosis, then you may have to think of interstitial lung diseases and not the obstructive lung disease. So if you see in cases of emphysema, they are mainly without fibrosis. We have to differentiate emphysema from overinflation. Overinflation means that there is no destruction. If you remove one part of the lung, the second part, the part of the lung which is normal in cases of pneumonectomies, the contralateral lung will be having some overinflation. But that overinflation does not mean that it is emphysema, because there will be no destruction of the walls of that lungs. Anatomically, they are divided into these four categories. They don't really have much of a clinical significance. It is just an anatomical distribution. There is the most common type is centriacinar, with pan-acinar, distal acinar, and an irregular variety. Now, if you remember, we have discussed the concept of acini, we have discussed the concept of lobule. So centriacinar will be those types of emphysema which is mainly going to affect the respiratory bronchiole. So it is mainly going to affect the respiratory bronchiole, whereas pan-acinar will involve the respiratory bronchiole, it will involve the alveolar duct, it will involve the alveolus, as we know that this is what a normal acinus comprises of: a respiratory bronchiole, alveolar duct, and an alveolus. Whereas distal acinar will only involve the distal part. It will not involve the respiratory bronchiole, it will only involve the alveolar duct and the acinus. And the fourth category is irregular, which may involve all the three, and it's like a more of an irregular distribution. So centriacinar is also called as centrilobular emphysema. It involves central acini, mainly the respiratory bronchioles, whereas distal alveoli are spared. It mainly involves the upper lobes, apical segments are more involved, and mostly it is seen in smokers. Whereas pan-acinar category, is the one in which acini are enlarged from the respiratory bronchiole to the terminal alveoli. That means the whole of the respiratory bronchiole, whole of the acinus is involved. So that is how the name pan-acinar. And you know that 3 to 5 acini they comprise of a lobule. So we can also say that is pan-lobular, right? Because all of the acini will be involved in that particular lobule. They mainly involve the lungs, lower lung zones, and commonly are associated with alpha-1 antitrypsin deficiency, which is a type of an anti-elastase present in the lungs, and we will be talking about the pathogenesis of alpha-1 antitrypsin soon. The third category is distal acinar, which is also called as paraseptal, in which the distal part of the acinus is involved, which is mainly the alveolus and the alveolar duct. That means respiratory bronchiole will be completely spared. This is quite in contrast to centriacinar, in which only the respiratory bronchioles are involved, whereas distal alveolar ducts and alveoli are spared. They mostly are seen adjacent to the pleura because they will be quite in the periphery. So they will be seen adjacent to the pleura, and they are the ones which are mainly involved in formation of blebs or bullae inside the lungs. So this is how it is. This is the normal acinus, and one acinus comprises of a respiratory bronchiole. You have an alveolar duct over here, you have an alveolus over here. So if this is going to be a centriacinar, only this particular portion is going to be involved. That means there will be dilatation of the respiratory bronchiole. Why dilatation? Because there is some kind of obstruction which is present here. So when this obstruction is present, there is entrapment of the air within this area. You cannot really exhale the air out, right? The air can come in. It's like a ball valve mechanism. The air comes in, lots of air comes in, but not much air goes out. So this is going to cause over expansion of this particular portion. So when it causes this over expansion over a period of time, there will be some destruction of the alveolar walls. These walls will be destroyed, right? And there will be minimal amount of fibrosis. This is what is going to happen. Or same way, you have this pan-acinar, in which it involves the whole of the acinus, the respiratory bronchiole. It involves the alveolar duct, alveolus. So the whole thing is basically blown up. Again, because of the same reason, you can bring in a lot of air which goes all the way, but when it comes to expiration, you can't really exhale much of an air. So it leads to over expansion. It will lead to destruction of the alveoli. The pathogenesis is very simple. It is basically an imbalance between the protease and an antiprotease system. Now we have a protease, we have an antiprotease system. Both the things should go in a very nice balanced way, but if they have some kind of imbalance, they are going to cause problems in the way and will lead to emphysema. Now when a person smokes, the patient has a history of smoking, there will be some inflammation. Neutrophils will gain access to the alveolar spaces, and because of neutrophils, they contain some enzymatic activity, they contain some proteolytic enzymes. So these enzymes will increase its proteolytic activity. Now there will be low levels of serum alpha-1 antitrypsin. So these low levels of serum alpha-1 antitrypsin, they can be either congenital. So the patient may be suffering from alpha-1 antitrypsin deficiency. So this is basically a congenital. There is an absolute deficiency of alpha-1 antitrypsin. But this alpha-1 antitrypsin can also be functional. That means you have enough amount of alpha-1 antitrypsin, but because of smoking, the levels of alpha-1 antitrypsin, they go down, and this is called as a functional alpha-1 antitrypsin deficiency. So in either of these cases, it can be either congenital or it can be functional. They both will lead to decreased amount of alpha-1 antitrypsin. So this decreased amount of alpha-1 antitrypsin, when you have decreased amount of alpha-1 antitrypsin, it is going to lead to, yes, it will not let it is an antiprotease, so it won't have the check on the protease. So there will be excessive protease activity. Protease activity will be increased. So this protease activity is going to cause the destruction of the lung parenchyma. So here it is like this. You have tobacco smoke here. It produces nicotine, which is going to recruit a lot of neutrophils. Neutrophils come at that particular space, plus it also produces a lot of reactive oxygen species or free radicals. All these interleukin 8, leukotriene B4, tissue necrosis factor, all these things act as a chemotactic agent. It brings in more neutrophils. All these neutrophils will have a lot of elastase, because these alveoli, they contain a lot of elastase. They contain a lot of elastin. So increased neutrophilic enzyme, which is mainly elastase, is going to work on the alveoli and will cause damage to the tissue. So there will be inactivation of antiprotease. That means there will be a functional alpha-1 antitrypsin deficiency. So 1, there is increased neutrophil elastase. Number 2, there is decreased anti-elastase. Increase elastase, decrease anti-elastase. So there is an imbalance between elastase and anti-elastase activity. This is going to cause a lot of tissue damage. At the same time, these free radicals can themselves cause a lot of tissue damage, which we have seen during our foundation block when we have talked about free radicals or reactive oxygen species and so on. The patients who have congenital alpha-1 antitrypsin deficiency, they are the ones who mainly have a pan-acinar type of pan-acinar type of emphysema, whereas tobacco smokers, they mainly have the centriacinar type of emphysema. So finally, it will lead to tissue damage. Alveolar macrophages will be activated. They will also secrete more elastase. They will also secrete more metalloproteinases. So the final outcome is damage to the tissue. There is going to be damage to this tissue, and damage to this tissue is going to cause emphysema. There will be destruction of the walls without any fibrosis. So grossly, how the lungs will look like, because they are swollen, the lungs are bigger, the lungs have more air, the lungs are hyper expanded, so they will be pale, they will be voluminous because of more amount of air, and they are going to obscure the heart. If we look at the chest x-ray, if we see this in cases of centriacinar emphysema, they are deeper pink than as compared to the pan-acinar ones, because they mainly involve some of the area. So they are the central acinar. They will be less voluminous again as compared to the pan-acinar type, and mainly involves the upper 2/3 of the lungs. Coming to microscopy, there will be thinning of the walls because of expansion, because of stretching of the walls, because of air. So the air is entrapped, it is causing expansion of the alveoli, stretching of the alveoli. So there will be thinning, and finally there will be destruction of the alveolar walls. Again, destruction is because of reactive oxygen species. This destruction is because of neutrophil elastase. This destruction is because of lack of alpha-1 antitrypsin. This destruction is because of macrophages, which are going to produce a lot of proteases. So there will be thinning and destruction of the alveolar walls. So as they keep on destroying, they will finally merge into each other, and you will have a confluent larger alveolar spaces, which are the big alveolar spaces. Large airway spaces will be formed, and there will be loss of the elastic tissue. If you open up the chest in these patients, it's a very, very, very common finding in smokers, in those people who are working in such an atmosphere, in a lot of pollution. It's a very common. This is a very exaggerated form, but if you open up the lungs of the smokers, we can see these small blebs over the surface of the lungs. So all these thin, paper thin structures which you can see here, some of them are really large, some of them are really small, which are mainly seen on the pleural surface. These are the ribs which have been cut open here. All these are ribs, and you can see these small to large blebs, and if these blebs get punctured, or if something happens to these blebs, it will lead to pneumothorax. The air from the lungs will come into the pleural space and will lead to pneumothorax. Here you can see there are larger air spaces. Now somebody asked me that how will you differentiate this from honeycombing? Honeycombing, which is seen because of fibrosis. Here you will not see any fibrosis. In fact, the walls are really, really thin, and that is how they have become confluent. Normally you cannot see such a thing. You will see it's a very spongy lung like this, very fine spaces, but if the spaces go bigger, huge, bigger here, they become bigger here. So they become bigger, they are like very thin walls. Had it been honeycomb, there will be a lot of fibrosis. You can see a lot of whitish area, whitish things between, and they're really hard if you happen to touch these lungs. This is how it looks like. You can see that there is stretching of these alveoli. You can see damage to the alveolar walls. You can see here there is destruction. You don't see much of fibrosis in the walls. Again, I repeat, if you see a lot of fibrosis, this is going to be an interstitial lung disease and not a obstructive lung disease. You can see here stretching. You can see some occasional type 2 pneumocyte, but mainly it is type 1 epithelium, which you see all over. Again, you can see all these, there is called destruction of the alveoli, and it leads to formation of these large air spaces. So if these large air spaces, if they keep on, you know, bursting into each other, and you have these larger air spaces, it will finally end up looking like this grossly, because whatever you see grossly is actually a manifestation at a microscopic level, and whatever you have clinically is basically a manifestation of the morphological finding which are seen in the lungs. There are some other types of emphysema which can be used as a suffix in a few conditions. There is something called as a compensatory emphysema. That means if you remove one of the lungs, this may lead to emphysema of the other lung, which is actually an overinflation, right? There is something called as an obstructive overinflation, which mainly happens in which because of some kind of subtotal obstruction by a tumor or by a foreign object, and this can actually be a life-threatening emergency if the affected portion extends a lot, if it extends a lot to compress the remaining normal lung. There is something called as a bullous emphysema, which refers mainly to any form of emphysema that produces large subpleural blebs or subpleural bullae. They can go all the way up to 1 centimeter in diameter, and they can be life-threatening because they can lead to pneumothorax. Now, the fourth type is called as mediastinal or interstitial emphysema. These are the conditions which results when air from the lung, from the air spaces, enters the connective tissue stroma of the lung, mediastinum, or into the subcutaneous tissue, right? So this is called as a mediastinal emphysema. These are the bullae, these are the blebs which you can see over the surface. You can see all these are very thin walled air spaces. So all these are bullae, and whenever they rupture, they can lead to bullous emphysema. Now, chest X-ray of a person who may be suffering from emphysema, as you can see that the chest is hyper expanded, and this hyper expanded chest is also called as a barrel chest, right? This is the patient may have something called as a barrel chest. So why do we call it a barrel chest? Because now we have to understand this concept that when these people are normally, we also did this exercise during our lecture, that if you are breathing, your resting phase is inspiration phase. You exhale, and whenever you are in your inspiration phase, that is your resting phase. But in cases of patients suffering from emphysema, what happens is the people who are suffering from emphysema, there is entrapment of air within the air spaces, within the smaller airways. So this entrapment is going to cause obstruction during expiration. So you have to breathe, you have to do an extra effort to squeeze the air out of your lungs. So your resting phase becomes inspiration. You feel more comfortable during your inspiration as compared to a normal individual who is more comfortable at an expiratory phase, right? So if you exhale, that is going to be your resting phase, but in this case inspiration becomes the resting phase. So the lungs are always expanded, the lungs are always broad, the lungs are always over expanded, and that leads to something called as a barrel chest. There will be flattened diaphragms because the lungs will be pressing upon the diaphragms, plus there will be blunting of these nice these nice costophrenic angles, which would have been very clear, very sharp. They are quite blunted. You can also see some bullae. If you have very keen radiological eyes, you may even find, or you may even catch some bullae, and these bullae or these blebs will be really black because of more entrapment of the air within these bullae, and there will be increased lucency. Increased lucency means there is more air inside the lung, so they will be more lucent. It's not something solid. There's something which is more airy, so the lungs are very airy, so they will be having. The patients may have dyspnea as the first symptom. So if we talk about clinical features, they may have dyspnea. They may have some associated symptom if they are associated with chronic bronchitis, or if they have chronic asthmatic bronchitis. They may also be having cough, or they may also be having some amount of wheezing. And if we do a pulmonary function test, they will be reduced FEV1 with a normal or near normal forced vital capacity, so that the ratio of FEV1 to FVC will be reduced. The classical presentation, if the patient is having only emphysema without any chronic bronchitic component, the patient will be having a barrel chest, the patient will be dyspneic, they will be having an obviously prolonged expiratory phase, they will be sitting forward in a hunched over position with a lips in a pursed lip pattern, and they will be trying to squeeze out the air out of the lungs. And these people, they have because of prominent dyspnea, they have adequate oxygenation, because the air is entrapped inside the lungs, so they will be having adequate oxygenation. So because of that adequate oxygenation, they are sometimes called as pink puffers. They may be sometimes called as, I will just write here, they may be called as where do I write here, pink puffers. They may be called as pink puffers, which is in contrast to blue bloaters, which are seen in patients who are having mainly the chronic bronchitic component without any emphysematous component. Now, what could be the complication in this patient? The patient will be may die of right heart failure. Why they will be right heart failure? Because when these people, they have hypoxia. Hypoxia will lead to it. It's a reflex mechanism that there will be constriction of the pulmonary vessels, and constriction of the pulmonary vessels will lead to pulmonary hypertension. I will come back to it once we finish all the 4 obstructive pulmonary diseases and talk about complications. Now the next topic is chronic bronchitis, which is more or less, as we have told you earlier, is more or less a clinical diagnosis rather than a morphological diagnosis as compared to emphysema. So chronic bronchitis is quite common again among cigarette smokers, which is quite similar to the patients suffering from emphysema, plus urban dwellers who are living in highly polluted cities, smog-ridden cities. They will be having chronic bronchitis. We have to make the diagnosis of chronic bronchitis clinically. That means when there is persistent productive cough for at least 3 consecutive months in at least 2 consecutive years, only then you will call it chronic bronchitis. So it is basically a clinical diagnosis. There is a lot of changes which actually happen in the walls of the lungs. There is hypersecretion of the mucus from the hypertrophy. So there is hypertrophy of the submucosal glands. Now this thing basically starts at the level of larger airways, but as eventually the disease progresses, it may also involve the smaller airways. So there is hypersecretion of the mucus from the hypertrophied submucosal glands, and there will be goblet cell hyperplasia, and there will be small airway disease which finally may occur, which is because of the goblet cell metaplasia. Now this metaplasia is because of smoking. There will be some amount of goblet cell metaplasia, right? So there will be plugging of the mucus inside the bronchiolar lumen. There will be inflammation, and there will be a lot of fibrosis in the bronchiolar wall. It can be simple chronic bronchitis, it can be simple asthmatic bronchitis, or it can be chronic obstructive. Now, whatever the type is, the basic problem with emphysema is basically hypersecretion of the mucus, which actually begins in the large airways, as I mentioned earlier, and finally may involve the smaller airways sooner or later. Now, this chronic bronchitis, initially the patient will only have mucus from the hypertrophied submucosal glands, so they will produce a lot of mucus, and that mucus is going to block the airways. So when there is blockage, there is plugging of the bronchiolar lumen, there is damage to the bronchiolar wall. The patient may finally end up having some amount of emphysema, which is actually destruction of the alveolar walls, right? Because of this chronic bronchitis, because of presence of a lot of mucus, because of presence of the obstruction of the lumen, there will be entrapment of the air. Initially the patient will just have cough because there is a lot of mucus being produced. The patient may not have any obstructive features, but slowly the patient will develop some obstructive feature. Now, we have seen here, there is one type of chronic bronchitis called as chronic asthmatic bronchitis. So these people may also have some features of asthma. That means they will be having some kind of they may demonstrate hyper-responsive airways, they may have bronchospasm, and they may also have wheezing, right? So these people, and when it turns into chronic obstructive bronchitis, these patients will have so these patients, these are the ones which are having simple chronic bronchitis. That means they will be having only cough with mucoid sputum, so they won't have any features of obstruction at this stage. Some people may have features of asthma, right? That means that they may have bronchospasm, they may have wheezing, right? So they may have these intermittent problems of bronchospasm, and then it may turn into obstructive, and when it becomes obstructive, it is associated with emphysema. That means when it is obstructive, in the sense that this is the alveolar wall, these are the, let's say, alveoli. So this is submucosal glands. Submucosal glands, they are hypertrophied. I'm just it's only schematic. We know that we don't have any submucosal glands at such a distal airway, but whatever. So there is mucus which is obstructing the airways. Slowly it is going to affect the smaller airways. It basically starts at the larger airways, and then it is going to involve the small airways as well. So this is going to cause obstruction, and this obstruction is going to cause entrapment of the air within. So the air is going to be entrapped within the small air spaces and will finally lead to destruction of the air spaces and will be associated with emphysema. So this is called as chronic obstructive bronchitis. So they all mean the same. That means, but you have to diagnose them clinically. If they have some associated findings like asthma, or they have associated finding of obstruction, then you may call them chronic asthmatic bronchitis or chronic obstructive bronchitis. But we still have to understand that they should have persistent productive cough for at least 3 consecutive months in at least 2 consecutive years. Grossly, they will be having the mucosal lining of the large airways will be hyperemic. They will be swollen again because of the bad effects of the pollutants. There will be all these irritants. They are going to produce all those CD8 positive lymphocytes, macrophages, neutrophils, the same pathogenic mechanism. They will be causing damage to the mucosal lining of the large airways, so they will be hyperemic and swollen. They will be covered by a huge layer of mucinous, and if it has some kind of infection also, there will be mucinous or mucopurulent secretions which will be covering the walls. Histologically, the most important feature is enlargement of the mucus secreting glands. So the basic problem, as I've said earlier, in chronic bronchitis is there is marked thickening, there is marked enlargement of the mucous gland layer. That means the submucosal glands which are present in the larger airways will be enlarged. There will be hyperplasia and hypertrophy of those glands, and once it causes lots of mucus production, there will be obstruction, and slowly the disease will reach the smaller airways as well. We have to understand the concept of Reed index. So this Reed index is basically it measures the increase of the size of the submucosal gland. So there's an index called as Reed index. In this Reed index, there is a ratio of the thickness, the whole thickness of the wall of the airway with the submucosal gland layer. So this ratio of this A thickness of the submucosal gland layer to that of the bronchial wall. So A is to B should be around the ratio of A to B should be around 0.4. Yes, it should be around 0.4. But in cases of chronic bronchitis, as you can see, there is hypertrophy and there is hyperplasia of these submucosal glands. There is goblet cell metaplasia, there is goblet cell hyperplasia, and also there will be goblet cell metaplasia. So you can see increase in mucous glands. So this is going to cause Reed index, which is going to be increased. So normal, which is 0.4, in this case it may go up. So the magnitude of the increase in size is assessed by the ratio of the thickness of the submucosal glands to the total bronchial wall, which is called as the Reed index, which is actually ratio of A is to B. It should rather be A is to B. The ratio of A is to B should be around 0.4. In this case, the Reed index will be increased. At the same time, there will be a lot of inflammatory cells, because basically what happens is all these chronic pollutants and cigarette smoke, they cause inflammation to the submucosal gland. So it's mainly starts, so though it mainly involves the large airways, but the morphological basis of airflow obstruction. So fine, the chronic bronchitis component, the component of chronic bronchitis, it mainly involves the bronchioles, it mainly involves the larger airways. But the obstructive component, when we have to talk about the chronic obstructive lung disease, so the obstructive component comes when it involves the small airways, and that is when the obstructive component begins. And plus it will also, so when this obstructive component begins, it will be associated with some amount of emphysema. So you have to understand this concept basically, that it basically starts in the large airways. All these inflammatory things will start in the larger airways. From the larger airways, there will be it will be causing all this mucus production. The mucus will trickle down all the way towards the smaller airways. There will be goblet cell metaplasia, mucus plugging of the bronchiolar lumen, which is called as chronic bronchiolitis. So from larger airways, it will lead to chronic bronchiolitis. So smaller airways are involved. So when they involve the smaller airways, there will be obstruction. And if you remember, initially we have said that obstructive lung diseases, they will involve the small airways. So the small airways will be involved sooner or later, and when these small airways are involved, it will be associated with some amount of emphysema as well. So that is called as chronic emphysematous bronchitis. Sometimes they also have some microbial infections. They will also be present, and that is why these people will have a mucopurulent sputum, because obstruction will lead to retention of mucus inside the airways, which will eventually get infected, and the patient will have a mucopurulent secretion. This is how it may look like, and you can see there is marked thickening. All these are the submucosal glands, right here, from here till here, all are the submucosal glands. So there is increased thickness of the mucous gland layer, and it is almost more than the double which normal submucosal gland layer. And you can also see, if you look very carefully, there is some amount of squamous cell metaplasia. Squamous cell metaplasia will occur because of cigarette smoke. So you can see some squamous cell metaplasia over this area, right? This is flattening of the superficial epithelia, which is quite evident in this slide. So coming to differences between chronic bronchitis, it starts with the large airways. There will be mucus hypersecretion inflammation, which is called as chronic bronchitis, but slowly it is going to involve the smaller airways at bronchioles. It is called as chronic bronchiolitis. There will be peribronchial fibrosis. There will be airway obstruction. So when this obstruction becomes, it may also have some component of emphysema. Pure emphysema, in this you have, it mainly involves the distal airways. It anyways involves the smaller airways. It involves the respiratory bronchial alveolar ducts and alveoli, depending upon which category. If it's centri-acinar, it's pan-acinar, it's distal acinar, or it is irregular, there will be loss of elastic recoil, and it is called as an emphysema. So this is how you differentiate between chronic bronchitis and emphysema. These are some of the differences which you can see here. Blood gas values are decreased in cases of patient having predominantly chronic bronchitis. There is obstruction, so they are called as blue bloaters, whereas there will be PO2 and there will be increased amount of PO2, and so they are called as pink puffers. They will be more pink as compared to the patients who are having emphysema. They will having more infections because of more of sputum which is present there, which gets purulent because of superadded infections. In this case, there is not much of mucus, so they have less chances of developing bronchial infections. Dyspnea is late, it's mild. In this case, there is early dyspnea because it is mainly involving the respiratory units, right? They're mainly involving those respiratory units in emphysema, those respiratory bronchiole, which are the respiratory units. So they will be having early and severe dyspnea as compared to the patient suffering from chronic bronchitis. In this case, there will be hypertrophy and of mucus producing gland. In this case, there will be narrowing of the bronchioles and destruction of the septal wall. Coming to the complications, they will be having a frequent incidences of cor pulmonale because of more of hypoxia. So more hypoxia. So if these patients have more hypoxia, there will be increased constriction of the vessels. So increased constriction of the vessels will cause increased pulmonary hypertension, and increased pulmonary hypertension will lead to right heart failure, which is actually the cor pulmonale. So they are more frequently. In this case, they are rare and will be seen only in the terminal stage. And on chest X-ray, there will be a large heart, prominent vessels. In this case, you will be having a small heart and hyperinflated lungs. This is one of the pictures I got from internet. In this case, this is medical students who are actually depicting pink puffer. You can see this is a pink puffer and this is a blue bloater. She is pink and she is puffing the cigarette, and this is a blue bloater. Bloater means they will be having. Why will these patients bloat? You know why these patients bloat? These patients will bloat because of right heart failure, right? Right heart failure is going to cause edema. It's going to cause edema everywhere. So they are going to bloat, and that is why they are called as blue bloaters. And you can see she's smoking. She's having this barrel-shaped chest, whereas this guy is having a big tummy because maybe of ascites. He's carrying a container in which he must be spitting a lot of sputum because he's having a productive cough for 3 months, for 2 years, right? So that fits into the diagnosis. So this is a pink puffer and this is a blue bloater. Thank you so much for listening.